Welcome to Webinar Wednesday with Palmetto Care Connections. I'm your host, Davia Smith, Director of Education at Palmetto Care Connections. Today, our good friend and partner, Carol Yarbrough, has joined us to review the CMS Final Physician Fee Schedule. Before we begin the presentation, I'd like to announce that this webinar is being recorded for educational purposes. Please mute your devices to avoid any audio disruptions. The webinar recording and slides will be available on PCC's website at www.palmettocareconnections.org within 24 hours. Questions about the presentation may be typed in the question box during the webinar, and all questions will be addressed at the end of the presentation. You may send me a direct message using the chat feature if you have any other questions. At the end of the webinar, you'll be asked to complete a brief webinar evaluation. We truly appreciate and value your input on future webinars. At this time, I'd like to introduce our speaker and present her to others. She is a healthcare compliance and reimbursement specialist. She provides a unique background in legal, technology, revenue management, clinic management, and knowledge of both federal and state regulations. She also manages telehealth and other e-visit initiatives at UCSF. She works hands-on with professional fee and hospital-based fee professionals to implement billing strategies and provides real-time feedback to clinicians regarding documentation and allied health staff. Carol also trains CPT coding professionals at UCSF Medical Center in order to maximize reimbursement through correct CPT coding. Carol, the floor is yours.
Hey, good afternoon, everyone, and thanks for joining in your mid-afternoon. I have to say it's a little bit friendlier to me on the West Coast here, so I'm so pleased that you're all with us today. I'm going to be talking about the CMS Final Physician Fee Schedule for calendar year 2022, and a few things to talk about. So these are our main points. These are the main points of the fee schedule for this year: the conversion factor, the expanded list of telehealth services, new coverage for telebehavioral, E&M changes, payment for PAs. I'm going to skip appropriate use. I'm going to skip Medicare diabetes. I'm going to cover ad nauseum RTM. And I'm going to skip those last two, but you can find more information about all of this, of course, on the web. And we're going to focus, and I just went through that. This is what we're going to focus on because telehealth and virtual care are our favorites. Disclaimer, the opinions expressed in this presentation on the following slides are mine, not necessarily those of UCSF or ZSFG or Palmetto Connected Care. Any mistakes are my own. I own it. This is Lena. She has her own opinions. The lump behind her also has his opinions about FedEx, UPS, USPS delivery personnel. They may contribute to the content of today's webinar, but let's hope it's a boring day at the Yarbrough household. Okay. So to get right into it, conversion factor for 2022 and sequestration, which is the reduction in federal payment, which began several years ago. We were supposed to be hit, if you recall, last year by a $3 reduction. Congress stepped in with the CARES Act and suspended that last year. So we were still making around, instead of $36, which was the 2020 conversion factor, we were making around close to $36 still. It was like $35.60. And of course, for most of you, I'm just, of course, speaking in tongues and not explaining myself. The conversion factor is so important to us because this is what we multiply the RVUs to. So if there is a 2.0 RVU attributed to a physician's work effort, say like a 99358, I think is a 2.0, or it used to be, that means we got let's see, 3460 times 2. That's the money we get. So that's why this conversion factor is so important. And you can imagine, and when they announced the conversion factor, I believe in November, there was a huge outcry, or even earlier than that. It was probably July, August, September, because due to having to keep the Medicare funds budget neutral, they'll attribute more RVUs to something that's new, like RTM, but then they have to subtract RVUs from other things, like surgeries. So the surgical specialties were hardest hit, because also, the care management codes were given higher RVUs, to keep people from having to get surgeries. So anyway, it all went back and forth. So as of, I think it was late November, the conversion factor per RVU is $34.60. That's 6062. You can round that up to 61 cents. So the CARES Act also required all health plans to suspend that 2% sequestration reduction in payments, which was part of something else, as opposed to the usual keeping Medicare budget neutral. So this is the fun part. If you're looking at the gray square with me, look at it with me. They're suspending the 2% reduction in payments from May 1 to March 31st, 2022. Well, what does that mean on April 1st? Yeah, April Fools. A 1% reduction will apply, and they're pulling the Band-Aid off slowly, so there's not a huge dip in revenue, I guess. So effective on April Fool's Day through June 30th, percent reduction applies. First, the 2% that was supposed to go in effect on May 1st, 2020, will be in effect on July 1st, and it's in line with the current CARES Act legislation. So I think what that means for us, the interpretation is, we're going to have to recalculate projections, relook at your budgets. We're in budget season now, probably, for a lot of healthcare systems. You have to build this into your budget so that you're aware that Medicare and perhaps, other affected trickle down kind of entities that receive funds from CMS are going to have these reductions. Sorry, I'm saying too much. Bugs me. Okay. All right. So let's stop talking about RVUs and Sturm und Drang and the terrors of less money and talk about really something great. So telebehavioral health. There have been permanent changes made. I hope you're all aware, but if you're not, it's only, I don't even know what day it is today. What day is it? It's only January 26th. Time to change there's still room for New Year's resolutions in terms of what you're billing and how you're billing it. So what CMS did for telebehavioral health, there are no geographic barriers that exist anymore post public health emergency. So this is forever and ever, or until they change something else. But this has been enacted for behavioral health, no geographic barriers, and patients can be in their homes as an originating site. And it can be audio, or it can be audio visual, video audio, visual audio. You know what I mean. It can be telephone, or it can be, your usual video visit. So anything, counseling, therapy, your substance use disorder treatment programs, especially in areas with poor broadband. And you do have to offer the video, option. But if the patient chooses to only wish to have telephone, regardless of their broadband, they can have telephone only. It's a patient's choice. And also, rural health clinics and FQHCs can also include audio only for their behavioral health visits. So yay for us, yay, we get to expand access to mental health services. I guess words to the wise for any of us with kids in college. He's going to play violin, but I would steer him towards mental health as a profession since there are so few. All right, enough of that. Now we're going to talk about the changes to evaluation and management visits. That's what that third square was. They've changed how split shared works. And this, mind you, is only in the facility setting. I know we have some attendees who are with facilities and some attendees on this call who are with physician-owned clinics or non-facility. So if you're with a non-facility, you can check your email really quick and come back to us after 2 or 3 slides. So split shared, because at a facility, you know how I go on about incident 2, if you've ever attended one of my webinars before, facilities cannot supply services incident to a physician. Why is that? Well, it's prohibited. But why is it prohibited? It's prohibited because there's no direct contractual arrangement between a facility employed person and someone with a medical group. So if you're in a facility setting and you do a shared visit between a physician and a nurse practitioner who are in the same specialty, same medical group, or not in the same medical group, you can be in the same billing group, medical billing group, but same specialty, say. I've got a neurologist and an NPP who specializes in neurology. They do their shared visit, and so the substantive portion is the key words here, or the key phrase. The payment will go out under the provider who does the most. So anyway, I laugh. It's just terrible. Here, let me go back to that. Where's my little cursor? Disappeared on me, but that's okay. I can continue talking. So the substantive portion, your NP goes in, does a 30-minute visit, progress, follow-up, patient, it's the subsequent day after the admission. And then the MD comes in for that shared portion, or that shared portion of their visit, and they spend 10 minutes. And if we're going to base this on time only, the person that did the substantive portion was the NP. The billing goes out under that NP. So that means NPs are paid 15% less for a professional service than an MD. So there are things to think about if this is your current billing model or your current care model in the hospital. And then this also extends to critical care services. We all have so much trouble figuring out what we really like to bill securely about critical care. As for most Medicare covered services, these critical care visits would need to be medically reasonable and necessary for treatment of illness or injury, or to improve the functioning of a malformed body member, meaning something that is going to stop working in a person's body unless you directly intervene. with time on the floor, time on directly spending only in the care of that one particular patient. So it can be concurrent care. This is how we billed before, but it's so nice to have them agree to that. So you can have a cardiologist provide critical care services to a patient, monitoring the heart, keeping the heart going, or taking care of some kind of venous type of intervention. And then a neurosurgeon, of course, could be performing critical care with that patient, as long as and it does say regardless of group affiliation. So it doesn't matter if you're in the same billing group. If you're in a different specialty, you can all just go crazy and start billing that critical care. Just kidding. As long as it's medically reasonable. And that visit and that time can be shared with a nurse practitioner now. So there's a new modifier, FS. Really just goes to just really any E&M. So if you're already doing E&Ms, and again, this is just for facility, so I'm sorry I'm just waxing on about this, but this has always been some kind of thing for many facilities, because perhaps a facility employs the NP and the physician is employed by the medical group. Well, you can't do a split shared visit between someone who works in a medical group and someone who gets paid by somebody else. There's no direct contractual agreement between. You'd be double dipping. The nurse practitioner is going on the cost report for that facility. So that's pretty much it. Facility settings, including inpatient, outpatient, OBS, ED, got your places of service there. Nursing facilities, for visits not mandated to be done by a physician. The first visit is supposed to be done by an MD alone. I'm pretty sure there might be another caveat to that mandated thing, but it is definitely in the final rule. So it's not allowed in your office setting, sorry. They made it allowable for critical care. Yeah, same group practice, same specialty. It can be new, established, initial, subsequent, as well as prolonged services. With the new E&M guidelines for outpatient, if the nurse practitioner spends 50 minutes in record review and prepping for the visit, sees the patient for an additional 10, so now we're up to an hour. The MD comes in, does their portion for 10 minutes. That's going out as a 99205, 99217, and it's going to be reimbursed at 85%. So that's important to think about for your workflows. So in 2022, we're talking about time or one of the three key components. So say the NP does the history and exam and the doctor comes in and does the MDM. In 2023, the substantive portion is only going to be based on time. Another slow rip of a Band-Aid, I guess. We're slow to change. All right, and then, here's the telehealth critical care consult information. And this is just really good to have for, what you need to document and what it is. And this can also be split shared, right? Oh, I just said right. Of course it can. So it can be split shared, split or shared. And what you want to do is, again, substantive portion is going to have to be the ruling factor for our telehealth consults. And those are those G codes at the bottom of the telehealth list. All right, we're at 11:20, moving right along. Teaching physician rules. So if using time to select an E&M code, use only the time the attending is present. Don't use the resident time. This isn't new to anybody, or it shouldn't be. Should not be new, but it was confusing for folks. It was confusing in the facilities I'm familiar with, like, oh, so my resident spoke on the telephone for 20 minutes and the MD came on for 5, so I can bill a 99442, or whatever the time equivalent of that moderate telephone encounter is. No, you can't. It'd have to be 5 minutes or greater and bill a 99441 for the telephone encounter, because you can only use attending time. Now, if the attending was on the entire time for the entire conversation, monitoring, they could say, I was there the entire time. I spent 35 minutes listening to the resident interact with the patient, because that's how I like to teach. That would be fine. Primary care exception. This concept is sometimes new to people. So as you know, that when your resident is training in a primary care setting, for the first 6 months, every time they see a patient, the resident or the attending has to come in, poking their head and say, hey, I agree with everything. You're looking great. Maybe, palpate something. And then they bill under, for the resident's visit. During the PHE, clinicians billing under the primary care exception can report level 4 and 5 services. So normally you can only bill up to a 99213, which is great for insurance carriers. And for, even if you get a level 5 visit, but the resident saw you the entire time without the attending actually seeing you, they can only bill up to a level 3, 99213. But this is during the public health emergency. They can do this. And also, because time was such a confusing thing, as I told you about at the start of my ramble on about teaching physicians, you can't use it anymore. Only medical decision making can be used to select the visit level. People get confused. Can my resident spend 20 minutes and then I spend 10 and then that's 30? No, because you weren't there the whole time. That's for any visit actually, but a resident's time cannot be used when the primary when their attending is not there, when their teacher's not there. So now it's only MDM. All confusion is now gone. Yay, we're happy. All right. Physician assistant services. Prior to this being enacted, Section 403 of the CAA, PAs could only receive reimbursement through their medical group or under an MD, and then they would get reimbursed kind of circumnavigationally. Now they can get direct payment. Very cool. They could always obtain an NPI, but now they may bill Medicare directly, reassign payment, and incorporate with other PAs and bill Medicare for PA services. They can form their own PA groups. Again, payment's going to be less, but that's okay. They're their own people now, which is awesome. All right, this is where I wax. Boy, I'm just kind of zooming along here. I had a ton of slides, but we'll have questions at the end. I hope you have a lot of questions. Just start thinking of them. Okay, so RTM, the AMA's prefatory language from the book. I'm not going to talk about remote physiological monitoring, maybe a little bit later on. No, definitely a little later on to compare the two. But remote therapeutic monitoring is the next new thing for CMS and for us. The AMA crafted these codes to only address musculoskeletal and respiratory system, therapy adherence to musculoskeletal, therapy response to musculoskeletal, same adherence and response to respiratory as well. There's a lot of room for other things, right, that I would love to see. Adherence and response to behavioral health modifications. Sorry about that. This is going to continue beeping up here. We'll just close it. So the data may represent objective device generated is what RPM directly addresses, or subjective inputs reported by a patient. For instance, I did my physical therapy today. I feel good. Or, my range of motion was 45%, and the next day it was 50, or, these kind of things. So those are subjective inputs. And it's going to give a functionally integrative representation of patient status. So really, it's just a way to keep you out of the clinic and doing your exercises, darn it, or working with your respiratory spirometer thing that you blow into to make sure that your lungs are filling up better by blowing into that thing and really breathing well. So again, like remote physiological monitoring, which is related to physiological signs and symptoms, like your vitals. That's all it is, your vitals. There are 30-day time periods. The services also must be ordered by a physician or other QHP, like an APP. There is an education code, like RPM. I'm going to assign this patient to watch this video every single day and perform these exercises. I can bill 98975 for that. It can be a clinical staff member, it does not have to be medically trained. The other codes, 9897677, report the device supply or programmed alerts transmissions. The device used must be a medical device as defined by the FDA. Again, software as medical device is somewhat narrow. I wish I was better about talking about that. If there are any subject matter experts on that, that would be great. You could give us a little tutorial on that at the end of my presentation. But again, since these are not pulse ox or anything like that, there's no PHE lessening of when you must report. Like for RPM, if you report pulse ox within 2 days and the data is automatically uploaded, you can bill the training and then the device and upload practice expense in 2 days. But like RPM, if it is not COVID related, and this is definitely not COVID related, you have to be able to bill these things within 16 days, because 16 days reported. Every other day within 30 days. Has to be 16. Don't report these with other monitoring services like CGM or RPM. I do believe if you are I'm sorry, I'm using the word believe. If you are in a different specialty and monitoring another type of thing, you may report these with one patient, on one patient, but you're with different specialties. Just don't report them on the same day for the same provider. Like I want to bill 98976 and 99454 because I want to monitor my patient's hypertension while they're doing their physical therapy. Can't do that. Sorry. Goodness. So 98975 is reported for each episode of care. There has to be a treatment plan. So the episode of care is when your patient and you decide, I'm going to do this, and then I am going to obtain a 90% range of motion with my arm, showing that my shoulder has been repaired, and that's when I can stop doing this. It's not one of those things where you bill forever. Okay. Now, let's talk about incident 2 again and direct supervision and the difference between RPM, RTM, and supervision. I have my eyes closed. I know you can't see me, but all right. CMS, this is a quote from the Federal Register. We finalized a policy that permits therapists and other QHPs to bill the RTM codes. The practitioner's Medicare benefit, say in a facility where you can't do incident 2, the items and services described must be furnished directly by the billing practitioner, or in the case of a PT or OT, by a therapy assistant under the PT or OT supervision. This is direct supervision. Now with RPM, they changed the codes. They took them out of the E&M section, moved them over to care management so that supervision could be done under general supervision. General supervision means you don't have to be in the same building. You're following a plan. Direct supervision means immediately available. Sort of odd. So if you can bill directly to Medicare, you have an NPI, you're a PT and OT, and then you're doing so great, you've got therapy assistants. I'm going to be in the same office suite. I'm going to be immediately available to that therapy assistant in order to bill their services under my direction. So the interpretation of that, which I tried to explain, if the performing provider doesn't have an NPI, you need to meet the supervision guidelines to submit for them. So this would work great in a standalone clinic. I'm in a non-facility area or clinic. I own my own business and say I'm an orthopod. And I can have employees that will perform work for me incident 2 or following a care plan I implemented. And I will be directly available to that PT. For the setup and education codes, direct supervision is also required if not performed by the person who is billing. So This cannot be done remotely. It can be done via telehealth if the supervising provider who can bill is immediately available to your clinic staff doing the setup. They have to be in the same place or on the same call, the same video visit. Good times. All right, again, here are the codes. We got RTM only. The setup code is the same for both. The next code is respiratory only. The next, musculoskeletal only. And then treatment management services, physician or other QHP, including PT, OT. I want to say respiratory therapist because that's pulmonary, right? First 20 minutes. If it takes longer than 20 minutes, each additional complete 20 minutes, not a portion of it. Each additional complete 20 minutes, 98981 can be billed. So just looking at the reimbursement, kind of look at some kind of return on investment for this. Here's your education, your clinical staff under direct supervision. It's 0.56 RVUs in a non-facility, because I can't bill for this in a facility. Well, I can bill it out on the UB04. It's what we decided for our PM, so I'm going with this for facility. This does not, if you're in a facility, this does not go out on the 1500 under a physician. It will go on the UB04 as a 98975. You get 20 bucks for that. Pretty cool. Set up 10 patients in a day, not bad. Practice expense codes continued. Here you got your respiratory, your musculoskeletal. Again, clinical staff is monitoring this. For non-facility, here are your RVUs. 55 bucks for each of these. For a facility, put it on the UB04. You also need direct supervision to do that, though, so be careful. Be careful. And then the treatment management, because you're not making medical management decisions. This isn't care management. This is treatment management. So they're meeting goals. So the MD, NP, PT, OT, I want to say RT, they are monitoring whether or not the patient is meeting those goals as set by these codes. 50 bucks for 20 minutes, additional 40 for the next complete 20 minutes. They call these sometimes therapy codes. The services can be billed outside the therapy plan of care only when appropriate. Okay. Yeah, just take a moment, let that sink in. All right. So for the billing of these, it's not telehealth, it's virtual care. So bill the codes only, no modifiers. Unless, always a caveat with me, there are 2 new modifiers to introduce to virtual care. If you're a PTA, use CQ. If you're an OTA, CO. What's your result in reimbursement? You get a 15% reduction. And then the place of service is where the service was provided. 19 and 22 go on the UB04. Like, there's no place of service for that. It's just going to be clinic. The rev code, I think, is 250. Don't quote me. All right. I want to give you the differences again between RPM and RTM. This is where the AMA had a few different ideas than, well, CMS interpreted their own type of interpretation of how they thought this would be best used. So RPM, it's vitals. RTM is not vitals. CMS, yeah, they agreed. RPM, not limited to a body system, it's just your vitals. You can use your earlobe to get your blood pressure or at least your blood oxygen level. RTM, limited. CMS would like to expand beyond 2 systems. I guess we're going to see how this goes. Everything is 16 days. You need to collect 16 days of data across the board to be able to bill. The device, they were seeking comments. They're still seeking comments about whether or not what FDA defined means in terms of the RTM interface, what it is. I mean, if I'm just uploading my own subjective information about how many push-ups I did in a day, I'm not using a device. But there is an expense associated with monitoring how many push-ups I did that day. Great. The data is auto-uploaded for RPM, and then AMA and CMS agree. Auto-upload or self-reported. You know, maybe you finish a video module and it automatically sends that information to your practitioner. Basically, anyone who can perform an evaluation and management visit can order stuff. So it's got to be an MD or an NP. Who can perform and bill? For RPM, your clinical staff, if you're in a non-facility and you're paying their salary, their hourly wages, you can have them contribute various amounts of time into that 20-minute increment of time. RTM, combined minutes as well of an MD and an NP, says the AMA. CMS, MDs, NPs, therapists, anyone who can bill Medicare. Got to have that NPI. All right. If anybody was left wondering about place of service 10, every once in a while I get a random question where someone says, wait a minute, what about this again? Why? So we think it's in support of the behavioral health at home as originating site extension of telehealth services given this year. And the definition for telehealth service also changed. So let's look at O2 first, because it's the first one on this list. Rendered by a physician or practitioner from a distant site. The originating site will fill the original originating site definition, which will be an appropriate originating site, such as a clinic, a hospital, and after the PHE is over, in an appropriate geographic site. It'll either be in a physician scarcity location or a geographically remote area, which will then result in not having a lot of doctors around. So the geographic and originating site factors will go back into place. So they're just making sure that people know that this is different from 10. So place of service is telehealth services provided in the patient's home. Of course, the physician or practitioner is at a distant site, wherever. There's no set, I guess the only set kind of advice about where a practitioner should be is not in a moving car and in a private place. But for place of service 10, patient's home also means, you know, where they are currently domiciled. That is not a facility, or like if they're domiciled in a facility, like if they're in a long-term care center, No, that doesn't fit either. This really just goes for patients' homes, or the car parking lot outside a library, that type of thing. Basically, it's saying they're not in an eligible originating site. Some payers look at your contracts, and I want to say it was one of the A's did report they do want to know where the patient was. So they want to know, even under the PHE, if the patient was at home or not. So they're going to want to know if it was place of service 10. It said it's effective January 1st. So, commercials can pick up on that. Anybody who wants to bill can pick up on that place of service 10, require that you use it. Available to Medicare April 1st. I think there's like this hope springs eternal that the public health emergency will be over. It won't be. This current extension is probably through mid-March. It will be extended another 90 days. I'm speaking as an oracle here, and also from just what I've heard from folks talking about it. But what you're supposed to keep doing is following the current PHE guidelines. So hopefully CMS will come out and talk about what place of service to use after April 1st under the PHE. In the meantime, just stick with what you're doing, unless you start getting denials from insurance carriers because they want 10. So be mindful, monitor your denials during this time, just to catch those switcheroos, right? The resources available to you from which I have pulled stuff, Federal Register, the files, and then the HIPAA privacy rule. Devices really aren't covered by this. Like, sure, they're portable. This is it's insurance information, healthcare information portability. I don't think it has anything to do with your iPhone. But still, the privacy rules do cover anything done via someone's smartphone, devices in their homes, secure networks, stuff like that. So be cognizant, make sure you've got your BAAs, or you're working through an encrypted portal when you're using RTM, RPM, or speaking to your patient on the phone, or using a video interface. And with that, I am finished, and I would love to take any questions.
Hi, Carol. It's Daisy, of course. Thank you for your presentation. We do have a few questions. I'd like to just announce again that the presentation slides and the recording will be available on PCC's website at www.palmettocareconnections.org. I will send a follow-up email to let you all know when that has been posted. So our first question is, in any circumstance, is an FQHC considered a facility, Carol?
No. It has its own place of service code, so that would be no.
Okay.
I always feel like Johnny Carson, where he had he would be reading a note on his forehead and say the answer before the question. That's what I feel like sometimes. Anyway, go ahead.
So this next one is about billing codes. Can 98975, 98976, and 98977 be billed for physician seeing patient in a skilled care facility?
Hmm. You know what? I want to say yes, as long as they don't need privileges. You know what? Let me get back to you on that one. My first instinct is yes, and usually my first instinct is no. Um, but there really are no place of service limitations put on any of those codes. So I want to say yes. If it's no, we'll get back to you. We'll change the answer.
Okay, so I do have who asked that question, and I'll make sure that that gets to her. The
Okay.
next question: can we have the resource that you use to determine that CMS will revert to using the POS02 as an indication that a patient is located in an improved presenting site?
Um, that is because it is in the FAQs, the CMS COVID-19 FAQs. And if you just put that into your browser and hit return, it'll come up. Anything under the PHE will revert to its original settings. It's like a factory reboot. So anything other than behavioral health will revert back to the before times. So, with these latest surges, just to give you a little bit of, seeing into the future, I was on a call where someone said, this is like she said, he said, she said, that they had spoken to someone in Secretary Becerra's office that they anticipated the PHE would extend through 2023. Up to and into 2023 is anyone's guess, but up to at least through the end of 2022, we're going to have a few more extensions. And remember, the last administration promised us 60 days notice before they ended it. So we have that. And that's my answer.
Okay. Are there any more questions? The other questions that we received were about the slides. So, again, the slides will be available as soon as possible and posted to PCC's website, as well as the recording.
Yeah, and if you think of anything else that is confusing about the slides or about the shared split, feel free to pass those questions on to Davia, and I'm so happy to research them for you and give you a response to them.
That sounds good. Sounds good. I'll give them one more minute to type in a question just in case someone is in the middle of typing. But I'd like to say thank you again to everyone. Thank you, Carol, for taking the time to share this information with us, always being our go-to for some billing updates and joining us all the way from the West Coast. We're thankful for you. This There will be a webinar evaluation that pops up when the webinar ends. Please let us know if there are any other topics that you are interested in. Also, please note if you missed our telehealth summit back in November of 2021, the recordings are posted for you to watch for free. So go to palmettocareconnections.org, and you can find those recordings. And again, I'll send a follow-up email. We do not have any more questions at this time, so you all have a great afternoon, and thank you for joining Webinar Wednesday. We hope that you will join us again next month.
Wonderful. Have a great day, everyone.
Bye, Carol. You too.
Thanks.